Hello everyone and welcome back. Okay, now coming towards the malaria. In this video, we will discuss the three infectious diseases, that is malaria, and then we will discuss the pertussis, that is whooping cough, and then we will discuss the chickenpox. And then we will discuss the mumps. These four topics will be covered in this video, that is malaria and pertussis and whooping cough and chickenpox and mumps. So starting from the today's first topic, that is malaria. We are having a 4 years old boy who is unwell for last 3 days, having chills and fever and headache and myalgia, and he is having a paroxysm of fever after every 48 hours, and on examination he is pale, febrile, jaundice and having herpes labialis. There is no lymphadenopathy but spleen tip is palpable and HP is 6.5 milligram per dl, and total leukocyte count is 7,000 per centimeter and platelets are 11,000. So in this scenario, there is history of chills and fever, headache and myalgia, and fever after 48 hours, and the patient is severely pale, febrile and mildly jaundiced, and he is having herpes labialis. So what is the cause of malaria? It is Plasmodium protozoa and the mode of transmission is female Anopheles mosquito. The differential diagnoses are meningitis, appendicitis, gastroenteritis, hepatitis, enteric fever, tuberculosis and septicemia. And the investigation options for malaria are clinical history, that is there will be the history of rigors and chills and fever that come after 48 hours, and the patient will be severely pale, febrile, mildly jaundiced and having herpes labialis, and also the patient is anemic. Okay, so now the blood smear is taken. That is gymsast and thick and thin smear, and the thick smear is done first for screening the parasitemia, which shows all blood stages of parasites, and thin smear helps in identification of the malarial species. Then immunochromatographic tests are done, and other tests are X-rays, CT scan, MRI, mammogram, ultrasound, PET scan, and pathology test. The clinical features are headache and rigors and chills, fever and anemia, and splenomegaly. The management options are supportive care and specific care. In supportive care, hydration is provided, antipyretics and blood transfusions are done if necessary. And in the specific care for Plasmodium vivax, oval and malaria, the drug of choice is chloroquine, and 10 milligram per kg is given, which is followed by 5 milligram per kg, and for hypnozoid primaquine is used. These are the specific treatment options. For P. falciparum, it is resistant to chloroquine, so quinine plus pyrimethamine is used, and cephalodoxin plus or mefloquine drug of choice is used for malaria. Now the prevention is done by environmental protection, that is wearing long clothing, insect repellents and mosquito nets. Chemoprophylaxis of the drugs, that is chemoprophylactic drugs are given once weekly and starting 1 to 2 weeks before going to endemic area and continuing throughout the stay and ending 4 weeks after leaving endemic area. Chloroquine is a drug of choice and it is given orally 5 milligram per kg. And for a chloroquine resistant P. falciparum, drug of choice is mefloquine or doxycycline, which is given for greater than 8 years old and who do not tolerate mefloquine. The complications of malaria are P. falciparum, that is cerebral malaria, black water fever, that is hemoglobinuria, and high output congestive heart failure, dehydration, adult respiratory distress syndrome, jaundice, severe anemia, DIC, hypoglycemia, circulatory collapse, tropical splenomegaly, and nephrotic syndrome. All these can occur due to malaria. So we have discussed the main clinical features of malaria, which are rigors and chills and headache and myalgia and fever, which comes after every 48 hours, and the patient is severely pale, febrile and mildly jaundiced and having herpes labialis, and there is no lymphadenopathy, and the HB is 6.5 and TLC count is 7,000 and platelets 11,000. So the cause to organism is Plasmodium protozoa and the mode of transmission is female Anopheles mosquito. And these are the investigation options, that is clinical history and blood smear and immunochromatographic test and other tests. Okay, so now coming towards the pertussis, that is whooping cough. So pertussis and whooping cough, we are having a scenario that there is a 6-month-old infant who has flu-like symptoms 1 month ago and he is followed by bouts of cough. Now the cough comes in a takes 4 to 5 times per day with flushing of face and vomiting, and the attack lasts for 1 to 3 minutes and is usually precipitated with feeding. On examination, the infant is malnourished and not febrile with no signs of respiratory distress or abnormal findings on auscultation, and X-ray chest is normal, but WBC is 20,000 with 90% lymphocytes. Now, what is the diagnosis? It is pertussis. The differential diagnosis is bronchiolitis, pneumonia, cystic fibrosis, tuberculosis, asthma, intrathoracic lymphadenopathy, and foreign body inhalation. The investigations that are done for pertussis is clinical diagnosis, and the two questions that are asked from the patient is that their history of fever is asked, and the history of incomplete vaccination or history of contact with the pertussis patients is asked. Blood counts, fluorescent antibody staining, and culture and X-ray chest is done. The management option is that general management is provided, that is adequate hydration and nutrition. The convulsions are treated by diazepam and oral phenobarbital and isolate the patient for first 5 days of the therapy. The specific management is any of the following, that is erythromycin 3 to 50 mg per kg per day in 3 divided dose for 14 days and azithromycin 10 mg per kg per day once a day for 5 days. The prevention is done, that is immunization with the DPT, there is diphtheria, pertussis, and tetanus. And the complications are bronchopneumonia, atelectasis, interstitial and subcutaneous emphysema, otitis media and sinusitis, convulsions and encephalitis, epistaxis, retinal and subconjunctival hemorrhage, intracerebral and subarachnoid hemorrhage, rupture of the frenulum, rectal prolapse, reactivation of the TB and apnea. The prevention is done as pertussis vaccine as part of the DPT vaccine, and erythromycin are given. So this was about the pertussis, that there are the symptoms of flu and cough, and the cough comes in attack 4 to 5 days with 4 to 5 times per day, and the flushing of face and vomiting. Attack lasts for 1 to 3 minutes and is usually precipitated with feedings. And the infant is malnourished and he is not febrile. So this is the diagnosis, that is pertussis or whooping cough, and the differential diagnosis are the following. And the following investigations are done. And are the questions that are asked from the patient. General management, that is adequate hydration and nutrition. In specific, erythromycin and azithromycin is provided, and prevention is done by providing the DPT vaccines. And these are the complications of the pertussis or whooping cough. Now coming towards the next topic, that is chickenpox. Okay, now coming towards the chickenpox. So we are having a scenario that there is a 6-year-old low-grade fever and malaise for 5 days, and then develop few red spots over her neck and chest, which changed to blisters in 2 to 3 days. Now she has macules, papules, vesicles, and pustules on her body. Another scenario is that there is a 2-year-old girl brought to OPD with complaints of fever and vesicular lesions over her chest and abdomen, with crusting of some lesions for the last 5 days. And she also complains of itching, and she is not vaccinated. And she is having nephrotic syndrome, and she is taking steroids. Another scenario is that 5-year-old girl presented with fever and vesicular rash all over the body, and she is not vaccinated, and some lesions are umbilicated and crusted. So in this scenario, we are having the clinical features of the low-grade fever and malaise for few days, and we are having the history of spots, which are in some cases papules, macules, and vesicles are present. In some stages, the crusting is present, and in some cases, the vesicular rashes are present and the patient is unvaccinated. So in the case of chickenpox, all the rashes are at different stages. Some will be macules, some will be papules, some will be vesicles, some will be crushing, some will be red rashes. So this is chickenpox. Now the definition is that chickenpox is caused by DNA virus 10 to 20 days, and it is contagious for 24 or to 7 days. And the mode of transmission is congenital, that is transmission occurs at any time during pregnancy, and the neonatal acquired, that is infants with mothers who develop rosacea lesions anytime from 5 days before delivery to 2 days after delivery, are at high risk for the severe fatal disease. And the acquired are respiratory droplets, that is the causes of vesicular rash and the causes of maculopapular rash. The causes of vesicular rashes are chickenpox, eczema, rash due to skin irritation or allergy, shingles, friction, bacterial infection, and herpes simplex, while the causes of maculopapular rash are allergies, measles, and atopic dermatitis. Now vaccines are given, which is varicella vaccine, and the dose is 0.5 ml, and the route is subcutaneous, and the schedule is the 2 doses at 15 and 18 months and 4 to 6 years, and the second dose may be given 3 months after the first dose, and the catch-up is complete to 2 dose series. The complications of the chickenpox are bacterial superinfection, most common after Staphylococcus aureus, and pneumonia, encephalitis, Ray's syndrome, which is associated with ingestion of salicylates, and hepatitis, and the infection during pregnancy. Teratogenic effects, that is congenital varicella syndrome, zigzag scarring of skin and shortened or malformed extremities, CNS damage, eye abnormalities such as cataracts or chorioretinitis. Severe varicella infections in the neonate may develop if mother acquires varicella within the 1 week of the delivery. And the management of chickenpox is that for immunocompromised or severe disease, consider a cyclovir skin infection and varicella zoster immunoglobulins, which is the supportive treatment. Immunocompetent supportive treatment is given, that is secondary infection, and proper hydration is done. Non-aspirin antibiotics to avoid the risk of Ray's syndrome, and calamine lotion is given to relieve the itching. Okay, for prevention, the isolation is done and no vaccine or varicella zoster immunoglobulins for healthy infants at the age of 0 to 12 months, and give vaccines in susceptible immunocompetent contact age greater than 12 months, and these are immunocompromised and susceptible pregnant women. Also for susceptible pregnant woman who is woman newborn whose mother had onset of chickenpox within 5 days before the delivery to 2 days after the delivery. The differential diagnoses of chickenpox are Coxsackie virus infection and impetigo and papular urticaria and scabies. So this was all about the chickenpox, that we are having the low-grade fever, malaise, and few red spots, macules, papules, and vesicles, and the crusting of some vesicles. So this is the definition, that it is a DNA virus, and the mode of transmission is congenital, neonatal, acquired, and acquired. Then we will discuss the causes of vesicular rash and causes of macular papular rash. Then we will discuss the vaccine. For chickenpox, varicella vaccine is given and dose is 0.5 ml, and it is given subcutaneously. And the two doses are given, one at the 15 months and other at the 18 months, 15 to 18 months, and the other is given at 4 to 6 years. The second dose may be given 3 months after first dose, and the catch-up is that complete 2-dose series is given. The complications are bacterial superinfection, pneumonia, encephalitis, Ray's syndrome, and hepatitis. And this is infection during pregnancy. And these are the management options for immunocompromised or severe disease, for immunocompetent and supportive treatment. And this is about the prevention of the chickenpox. And these are the differential diagnoses of chickenpox, which are Coxsackie virus infections, impetigo, and papular urticaria and scabies. Okay, now coming towards the next, that is mumps. So we are having a scenario that is a 5 years old child who developed high grade fever with earache. On examination, he was febrile, temperature 39 degrees C, and had swelling on both sides of his face, extended down and behind the earlobe. Another scenario is that there is a 5 years old boy who came with complaints of swelling and fever for the last few days. The parents also noticed swelling around the angle of jaw. Swelling has increased in size since then. He is complaining of headache and vomiting. So in this scenario, we are having the clinical features of high grade fever with earache and febrile, and had swelling on both sides of his face, which is extended down and behind the earlobe. And then a scenario is that there is a 5 years old boy who come with pain on swelling and fever for the last few days, and the parents has also noticed swelling around the angle of jaw, and swelling has increased in size since then. He is complaining of headache and vomiting. So the definition of the mumps is that it is acute contagious viral disease, and it is characterized by painful enlargement. Okay, this is acute contagious viral disease, and it is characterized by painful enlargement of the salivary glands, especially parotid gland. And the causes of the mumps are RNA virus, and incubation is 14-24 days. The investigation is clinical. Leukopenia with lymphocytosis is present. Serum amylase level is elevated. Virus culture is done in enzyme immunoassay. For mumps is done, that is IgG and IgM is checked. And IgM antibodies are present in acute illness. The differential diagnosis of mumps are cervical adenitis, suppurative parotitis, recurrent parotitis, and tumors. And the complications are meningoencephalomyelitis, epididymoorchitis, pancreatitis, deafness, and miscellaneous complications. The management is that no antiviral treatment is available. The supportive treatment is analgesics, antipyretics, and bed rest, semi-solid or liquid diet to avoid the pain on chewing. And prevention is that passive protection is not indicated, and children should be vaccinated. MMR at the age of 12 to 15 months is done. So this was all about the mumps. We have the clinical features of high grade fever and swelling on the both sides. So it is acute contagious viral disease, and it is characterized by painful enlargement of salivary glands, and it is caused by RNA virus, and the incubation period is 14 to 24 days. And the clinical investigations are leukopenia with lymphocytosis, serum amylase level elevated, virus culture is done, enzyme immunoassay for mumps, that is IgG and IgM is done, and the differential diagnoses are cervical adenitis, suppurative proctitis, and recurrent proctitis. The management options are that there is no antiviral treatment available, and the supportive treatment are analgesics, antipyretics, and bed rest. Semi-solid or liquid diet to avoid the pain on stomach. And these are the complications, that is meningoencephalomyelitis, epididymoorchitis, pancreatitis, and deafness and miscellaneous complications. In the next section, we will discuss all the serious diseases, and it is the important one are tetralogy of the Fallot and the tetralogy of Fallot and the transposition of great arteries. We will discuss these topics in the next part. Thanks for watching.